please. I'm delighted to welcome Professor Sir David Spiegelhalter to give this year's BAUS guest lecture. David is the Winton Professor of Public Understanding of Risk at the University of Cambridge, which he joined from the MRC in 2012. He's previously served as a research assistant at Brunel University back in 1976. And since then, I think it's fair to say that he has had both a peripatetic and a hugely interesting career covering a large number of areas. He was visiting lecturer at the University of Berkeley from 1977 to 1978, and following his PhD was a research assistant at the Royal College of Physicians, and he subsequently then joined the Medical Research Council. He was an honorary lecturer at the University of Hong Kong since 1991, and has also been a consultant to the pharmaceutical industry, working with GlaxoSmithKline, Novartis, and latterly the World Anti-Doping Agency. In addition, he played a leading role as a consultant to the Bristol Royal Infirmary inquiry and also the Harold Shipman inquiry. Between 2007 and 2012, he divided his time between the Statistical Unit at Cambridge and the Medical Research Council. And he's also well known in terms of his television appearances. So David, over his career, has been honored with the Guy Award from the Statistical Society on two separate occasions, in 1985 and also getting a Silver Award in 1994. Subsequently given an OBE and then was knighted for his services in 2014. So it's a real pleasure to have David with us this morning, and he's going to speak to us about communicating with men about prostate surgery, something that's of enormous importance irrespective of the nature of practice we have. David, you're very welcome.
Okay, thank you very much indeed. Great, thanks very much. Okay, thanks very much. It's wonderful to be here. I'll just point out I'm Winton Professor, so I'd like to give thanks to my philanthropist in Winton Capital Management, a hedge fund, who pays me and my team to do the sort of stuff I'm going to be talking about today. Okay, we work on risk communication, and it's particularly the public understanding of messages in the news or in their medical treatment. So, for example, there's a recent story: bacon, ham, and sausages have the same cancer risk as cigarettes, warn experts. No, they don't, and experts didn't even say that. However, this research was so badly communicated that that's a take-home message that was being propagated in the media. What in fact it was the World Health Organization saying that 50 grams of processed meat, that's about two rashers of bacon, a bacon sandwich, increases the risk of getting bowel cancer by about 18%. Okay, so that's a relative risk communication. It's well known to be a manipulative frame, as it's known by psychologists, that this is a way to make things look big. And actually, if we want to get a real understanding of what risk means, we need to think about absolute risks. We need to think about, is that 18% important? And journalists know this. They know they should be looking at how many people get bowel cancer. Anyway, about 6%, and we're talking about an 18% relative increase over 6 percentage points. Unfortunately, I know of no journalists who can actually do that calculation. They really struggle with it. Now, the way to do that calculation is something I'm going to be talking about throughout the talk, which is to use this idea of expected frequencies. What does it mean for 100 people? So 100 people, like you, smug, middle-class, professional people, eating your granola and berries in the morning, I know the sort. Sadly, 6 out of 100 of you will get bowel cancer during your lifetime anyway. Let's compare that with 100 slobs eating a great big greasy bacon sandwich every day of their lives. Oh, did you notice that's how many will get bowel cancer? See that? That one down there, that's the 18% increase over the 6%. So that's 100 people eating that every day of their lives for one extra case of bowel cancer. It's a very different way of telling a story. And if you tell the story that way, people might say, oh, well, pass the brown sauce. I mean, anyway. So who had bacon this morning? Yes, right. Start the day with a carcinogen. That's what I say. So obviously, maybe you don't want to be shoveling that down every day of your lives, but once in a while, it's not such a bad thing at all. So, okay, so that's the idea of putting risks in perspective, of using units or imagery or telling a story in a way that people can understand better. In fact, well, we got this by the time this story came out, by the BBC 6 o'clock evening news, they were using this metaphor, this way of explaining it to people. So you can have an influence by trying to change that. So we've now got this centre, Winton Centre for Risk and Evidence Communication, that works on this kind of thing. And how dangerous, this is a recent blog, how dangerous, and people remember earlier this year, the burnt toast, you know, the terrors of burnt toast. How dangerous is burnt toast? Not at all. Anyway, so that's I won't go into the burnt toast story, but that's another example. That was an example where they couldn't even say what the risks were because it's unmeasurable. Okay, so let's consider risks in the element of prostate cancer. So let's consider, for example, a man, 63, had a radical prostatectomy, PT3A, N0, M0, PSA of 10, Gleason 8, extraprostatic extension, negative margins. What's his prognosis? Now, I don't want to vote on it. You get your phones out and vote about the chance of him living 10 years or something like that. What's his prognosis? And what could he have been told when deciding on therapy? So that's the issue, sort of issue I'm going to talk about. Okay, so he could go on to various websites, and they'll concentrate, this is the one prostate calculator, 10% chance of treatment success, avoiding PSA. Doesn't give a time, presumably, you know, forever, I don't know. We could go on to this one. It'll give you the chance of being recurrence-free. So risk is all in terms of recurrence on these web calculators. It'll give you a chance. Or you can go on to Memorial Sloan Kettering one, and it'll tell you probability of remaining recurrence-free after so many years, and 15-year prostate cancer-specific survival. Prostate cancer-specific survival. Won't give you overall survival. So there are these measures. Now, I don't know how many people use these or recommend that patients actually look at these things, but we don't know. They're on American cohorts. A lot of them are rather old. Actually, how reliable are these to the patients that you might be seeing? Now, so some quick observations. My guess is that few people actually ask or demand this kind of information. What are the long-term outcomes? Maybe not many actually want to know, want to be told about these numbers. But for those who do, where is the reliable, up-to-date information that's relevant to their cohort of people? So for those who do, where is this information available? Now, let's contrast that with a woman, another 63-year-old woman, for example, newly diagnosed with breast cancer. Now, it's a different kettle of fish for women. They've got an NHS Predict site they can go on to that's designed for use in MDTs, but actually now is increasingly being accessed by patients themselves and their families, and certainly used in the consultation between the clinicians and the patients. So, for example, they could put their information into the NHS Predict site and blah, blah, blah. I'm not going to go through all the details, but there's a 63-year-old woman newly diagnosed with breast cancer, and then they click on the button Predict Survival, and it'll come up with 5 and 10-year overall survival, all-cause survival, and with a little indication there of what the benefit would be in overall survival by different treatments, by starting adjuvant hormone therapy and a little sliver for additional benefit, adjuvant chemotherapy, conveyed in a bar chart. I'm a statistician, so always look at how is this information communicated, but also communicated using the idea of expected frequencies, like the bacon sandwich. So for 191 out of 100 women are alive at 5 years with no adjuvant therapy after surgery. An extra 2 will be alive because of hormone therapy, and an extra 2 if they have chemotherapy as well. So then the crucial decision for that woman might be, is that gain, that 1 in 50 chance of benefiting essentially after 5 years, worth the side effects of the treatment? Is that big enough a benefit to her? Which is a decision, and actually, maybe it is, maybe it isn't. It can depend on the person. But at least the information is there for people to make a balanced judgment in terms of the absolute risk. Because think of bacon sandwiches all the time. Think of bacon sandwiches. That's the way to think about cancer prognosis. What does the bacon sandwiches mean for me? Okay, they could also go on to, that's based on the UK data, they could go on to an American site, Breast Cancer Math. There's lots of sites, but this is just one I've chosen that also shows survival curves. This shows, but I wanted to illustrate the different formats that this could be communicated in. See, that was 5 and 10-year bar charts and expected frequencies. Here we've got full survival curves, both for, let's see the click. This is for all-cause survival, and breast cancer specific, and non-cancer mortality, and cancer mortality essentially there. Add those together, and that's all-cause survival at 15 years. You can also ask for mortality curves. This is the idea of framing. Do you do it in terms of deaths or mortality or in terms of survival? Makes a difference to how people perceive it. It's important, the framing. The pie charts, horrible pie charts. Sorry, I'm trying to do ghastly things. Never use pie charts. Anyway, they can give pie charts, etc. And you can do it with bar charts, and said all sorts of other ways. Okay, so there are all these different options of how to communicate numbers. Let's assume the numbers are actually there and available. How do you actually tell people about it? Now, again, I don't want you to vote on this, but just think about if you had to tell someone that about 20% of cases with their condition roughly would suffer a certain bad outcome within 10 years, maybe be dead or whatever. Would you use the terms? You could use 20% chance of you having this event, 20% probability, 1 in 5 chance, 20 out of 100 cases like you, none of the above. Wouldn't use numbers, depends on the audience, the person. Now, I'm not even going to take a show of hands. Just think for a moment about what you might do. My guess is that many of you might say 20 out of 100 cases like you, or 1 in 5 of people like you, which is, again, the expected frequency format, which is generally what's recommended. So there's quite a lot of research on this kind of thing in psychological literature. I spend all my time working with psychologists now. One of the things they point out is the dangers of the 1 in statement. About 1 in 5 people like you, 1 in 10 people, 1 in thing. A single statement like that is very effective. I did that with the bacon sandwich. 1 extra case illustrated among a group of people. But lots of 1 in X statements can be very confusing because people find them very difficult to compare. So, for example, a fairly recent survey, 2010, said, ask people which of the following numbers represents the biggest risk of getting a disease. 1 in 100, 1 in 1,000, 1 in 10. Now, I'm not going to test you. Don't worry, don't panic. This isn't an exam. I won't ask you to get your phones out. So what I want to say is that how many people do you think got that wrong? Germany, 28%. USA 25% got that wrong. Because you've got to do a real mental inversion. The biggest number is associated with the lowest risk. That's why flood risk, to talk about 1 in 100-year event and compare it with a 1 in 1,000-year event, is really bad communication. You've got to do that mental twist. You're changing the denominator and keeping the numerator fixed. You should keep the denominator fixed and change the numerator. So the biggest number is associated with the biggest risk of chance of the event. Keep the denominator fixed is the bigger thing. So the generally recommended format for risk communication is this idea of expected frequency. What does it mean for 100 people like you? Now, how you illustrate that is another matter. Whether you draw them or just use that as a statement is another issue. I'd just like to point out an area where that's been used widely now is in the breast cancer screening leaflets and other screening leaflets. I was on the group that drew these up, and the powerful thing about these is that they were based on the idea of consider the offer. The previous leaflets used to be really trying to persuade people to go for screening, but the new leaflets don't actually recommend screening. They try to do a balanced communication of the harms and benefits, introducing this idea of informed choice, of shared care, of the patient allowing their own values to come into the decision, having been given balanced information, non-coercive information to make that decision. Something that's very relevant and actually was embodied in these leaflets. And again, the thing that was important about the development of these leaflets is that they were developed with the public. This was a co-production, not only on the committee, but through working with a citizens' jury to say what kind of formats did they like. And I had to sort of present the information in different formats, and bless them, the formats they liked were the ones I would have chosen anyway, which is the expected frequencies. What does this mean for 100 women? And so, for example, this is the page out of the leaflet that says what going for a mammogram might mean. Is no mention of the sensitivity of the test or the accuracy or all that stuff, which is very misleading. Much better just say, well, out of 100 women going for breast screening, 96 can go home with a normal result, reassurance. 4 will get more tests. It doesn't mean you got cancer. Even though the test, in a sense, is 90% accurate, it doesn't mean you got cancer because it's a rare condition. Most women who get recalls have not got cancer. So clearly explained in an expected frequency format. Okay, so, and I should just give a little plug, if anyone knows any teachers. We've written a whole book now for secondary school teaching probability using this idea of expected frequencies as a very powerful way to communicate risk and uncertainty and deal with probability problems. It's in the GCSE syllabus now. Expected frequency trees are now is now in the GCSE syllabus. So even if journalists can't do it, in the future the kids will be able to do it with luck. And they can, okay, this is also a lovely one. You know, okay, expected frequencies, but even that is subject to our biases. Here's a nice problem. Again, I'm not going to test you. This is a question done on Americans. You've got two bowls, one with 10 red beans, 10 beans, and one of them red. Another bowl with 100 beans, and 8 of them red. You get a prize if you pick a red bean. Which bowl do you put your hand into? Now, you're clever, sophisticated audience. You can do the sums. You would say, I'm sure that it's better to put your hand in this one because the chance of winning is bigger. Majority of people who test on this will choose the right-hand side. There's more chances of winning. The numerator is bigger. People focus on the numerator. It's known as denominator neglect. People look at, so I can make a number look big. Instead of saying 2 out of 10, if I say 20 out of 100, it looks bigger. If I say 200 out of 1,000, it looks even bigger. This is another reason for keeping the denominator fixed, because you can manipulate people's impression just by changing the denominator. So all this is, known, very well established in the psychological literature. Okay, so one thing I should say is that our team at the moment is working to revamp the predict front end to make it actually much more suitable to be used in consultation with patients. And that means making a better interface, but it also means choosing, if we're dealing with patients as well, how should they see this information? This is pretty harsh information to be giving people. How should we do it? And that means working with patients. So this means that we've started doing some focus groups on this. Shared decision making. To be able to look at the different options, if you're being offered alternatives, I'd want to take ownership of that. So people are very keen. I mean, this is just an example, but it's generally found, on having this information, on engaging with this. People want to do it. However, there's some real dangers. Quite casually, for the MDT, it's fine to have a button saying predict survival. Is that what patients want to see? Predict survival is a button. Oh, they didn't, this woman really didn't like that at all. I'm not on the website to do it. I'd sit there heart pounding crying, I want recommended treatment options. Just saying, oh, how long are you going to survive? Just like that. Really harsh. Icon arrays. We suggested these way of laying out the icons. That's horrible. Too sad, scary. I'm asking myself, which one am I? Which is actually, of course, what you're supposed to ask. That's the whole point. Which one am I? Yeah, we don't know. It's like you're one of these at random. We just don't know which one you're going to be. Didn't like all the people. That scared me. The bar is less emotional. So although one might use expected frequencies as a metaphor, actually showing these little people could actually might be counterproductive, unnecessarily worrying. So it's again, we've got to really test these things, test and test. So what are the right graphics? Now, you can take a picture of that if you want. I don't want to go through all this in detail. The main thing is that there's been a lot of research, but it's still not as if there is a single answer to this. It depends on the audiences. Nothing too fancy and not clever. A good table is really valuable, a really good table. Use words and numbers. Complex icon arrays, you shouldn't have to count little people. No pie charts. Bars are good. Bars are good because you can just look at the heights, the relative heights. So you can get a gist feeling without actually looking at the numbers. Line graphs can be okay. We're going to look at survival curves. We've done some randomized trials on survival curves. With good explanations, people can understand survival curves, even multi-state survival curves. So, don't, just because they look complicated, they can be answered, but you need good explanation. And you've got to test and test again. Good explanation and test again. But the survival curves can be all right. If you go into patient forum, you find all sorts of interesting things. Again, a fantastic source of information about how people judge what's going on. For me, it's a yes or no. Will it come back or won't it? Has it come back or hasn't it? Percentages are sometimes hard to grasp. So there's people having trouble with stats. is either going to happen or it isn't. What does it mean to be for chances? I hate these things. I see them as a tool to inform your oncologist, but don't frighten yourself. So I don't want to see them. I don't want to see them. Actually, some people will learn from them. I'm very shocked to see a little extra protection. So people can derive information from these, and they might want to. I'm correctly identifying that they don't actually trust them very much, because maybe they're out of date. So, and this is one I really like, shopping around. Look for the calculator that gives you the best chances. Yes, that's the way to do it. So there's going to be lots of responses to the development of anything like this, and these people are not stupid. They may be, sort of limited level of statistical knowledge, but people are not daft. They can identify the issues with this. Okay, so just a quick revision. Huge generalizations about shared care and informed choice. People vary hugely in their needs, understanding, and numeracy. As all you know, deal with patients. Enormous variability from, Cambridge professors or whatever to everybody else, to other people, all these different groups of people, different demands, different urge to know, different ones, some just not wanting to know at all. But people want advice from a trusted source. They do appreciate the information. I think it's a general finding. People would like to be told information. A lot of the time, more concerned with side effects than long-term outcomes. I actually find it quite difficult to deal with long-term outcomes because everyone has to deal with their own mortality. We'll come on to that in a moment. And actually, though, providing information, it's been shown repeatedly, actually has quite limited direct effect on behavior. But it can enormously improve people's satisfaction with the decision that has been made, and when things don't go so well, a feeling that they were engaged, that this was what seemed the best thing to do at the time, and they were properly informed. So enormously valuable for future considerations. Okay, back to prostates. Now, it's interesting in prostate stuff, particularly prostate cancer research, that it's very much geared up to prostate cancer-specific outcomes rather than all-cause mortality. Notice PREDICT and CancerNet CancerMath did all-cause mortality as their main communication. So, for example, if you go on to CRUK and ask about prostate cancer survival, you find, a very broad group, they're bunging everyone in together, but it's prostate cancer's net survival. This is prostate cancer-specific survival, and essentially removing all other causes of death. If you go on to the latest STAMPEDE study, abiraterone, we can see this again. It says overall survival. It's not overall survival. It's prostate cancer-specific survival. If you go on to the PROTECT study, again, we're looking at prostate cancer-specific survival in the three groups. So that's the standard way in which research is communicated to the trade, you lot. Okay, is that the way it should go to patients? That's one of the crucial issues. Okay, so to conclude, because I like to leave time for some questions, the testing, PSA testing or the other testing for prostate cancer, becoming more and more sensitive. I mean, there's going to be more and more diagnoses of prostate cancer. I think, you've got a lot of customers coming your way. And given, particularly for early stage, as the PROTECT study shows, the actual, similarity in long-term outcomes in many of these treatments, there seems to be an increased role for patient choice. This is absolutely inevitable. More and more role for engagement. Consider the options, not a single clear path at all. So that means there's an increased role for careful communication in the way that I think has been very much studied in, I'd love to know the difference between women who go to a breast cancer clinic, men who go to a prostate cancer clinic, what the difference is in terms of the communication they get. And some patients and their families would like to see the stats, not all, in any way at all. And even if they then say, well, what do you think I should do? I'm sure a very common reaction is for your patients is for them to say, thank you very much for telling me this information, what do you think I should do? That's absolutely reasonable. However, without having given them information is pure paternalism. Okay, so other conclusions? So if there is to be a PREDICT for prostate, which I feel there should be, the crucial things to consider is, are there different pathways or defaults for MDTs and patients? We're thinking we're still exploring that for PREDICT. If patients are going at it, should they see different things? In particular, should they get all-cause mortality? or should they see the cancer-specific mortality, even though the MDT might want to start off with all-cause mortality as being the crucial absolute difference that's important. Patients really are interested in the side effects, absolutely crucially, but the MDT might not be so much. So they know about that. They want to know what the gain in survival is going to be. So different pathways to faults. Crucial thing, background risk. Do you tell people as part of it just the chance of dying something else over the next 10, 15 years? Because this is a real shock to people that they're going to die. I don't know, you know, we live our lives with the knowledge we're going to die, but we don't particularly like being reminded of it. So, you know, it's a double shock. First of all, you got cancer. Secondly, oh, you were going to die anyway. It can be a bit of a blow, a double whammy, which might not be so great. How much prominence to give to side effects and the treatment benefits in the different interfaces that you might build. Okay, the point is that this is a fast-moving field with constant changes, need for new data, but I think you can build on predict, and our aim would be to, if we're working on this, to build on predict. And I should just make a comment that Victor Nanaprasagam is working on something like this. He's talking about it later on Wednesday at the conference on new prognostic indices being developed with the aim of building a kind of predict for prostate cancer, which I think will be a very valuable thing. Okay, just to finish off, our little prostate man, well, you know, what is his chance of survival without his cancer? And this is quite a tricky issue. You know, what is the chance of, you know, of us living for the next 10 years? Because as I said, this can come as a bit of a shock. So, for example, the 63-year-old man, on average, using, 2006 life table, so this is slightly old-fashioned, but hasn't changed that much. It got a bit better. Well, the chance of living another 10 years, up to 73, it's about 83%, according to that, on average. So about a 17% chance that he's going to die anyway, essentially, or on average. Now, you could say, oh, well, I'm a healthy person, or somebody could say, I don't smoke, and I don't drink, and I blah, 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 or don't drink too much, and physically active. And if you do that, yeah, the chances of surviving go up to 10 years, go up to about 87% or something like that. So, but still, 13% chance, according to this. Now, this is where some paradoxical behavior starts coming in. Even this is an underestimate of the survival. In other words, even this overstates the risk for most people. Now, here's a curious phenomenon. This is pessimistic. Most people are at less than average risk. Now, this is quite strange. Now, let me explain why that is. The point is, if you ask, those hazard curves that consist of, 63-year-olds, 1% will die in the next year or something like that. But that 1%, most of them are already ill. They've got some sort of really chronic illness of some kind. So most of the risk each year is comprised of people who are already ill. They soak up most of the risk. And most people are much less chance of dying next year than these curves would indicate. So over the short term, most people are at less than average risk because a few people soak up most of that risk and they're already ill. So this is quite a paradox that you look at those survival curves for the country and most people have got better survival than is shown in that. It's really quite bizarre. But of course it is related to the issue of that most people have got more than the average number of legs, because the average number of legs is 1.99999. So most people have got more, and perhaps the most misleading average of all, one that almost nobody has at all, is the average number of testicles, which is 1. Okay, thank you very much indeed.
David, thank you for a wonderful talk. I enjoyed it enormously. We have time for one or two brief questions. Dave Shackley.
It's a question about asymmetry of evidence.
Yeah.
In the media, you may have, say, climate change, where the evidence suggests 99.9% think one thing and 0.1 the other. How do you think that you should get a balanced public perception of that risk for the discussion?
Okay. Because of what the media, the report. Yeah. This is about communication risk, the fact that, you tend to get balance means that, can mean naively that you give both sides equal prominence. And no, that's a real problem, because you do want to point out there are different perspectives, but that doesn't mean they've got equal weight. And I think the way to do that, again, is by good, clear, numerical, communication. Like 97% of climate scientists think that, climate change is largely due to, man-made. So, you need to show very clearly that just because there's two perspectives, it's like, looking at outcomes. Just because there's two outcomes doesn't mean it's 50-50. Although some people might think, oh, it's 50-50. No, it's not 50-50. But that's quite difficult. That's why I think, some imagery of saying, well, of this many, I like the image of possible futures for you, the way things might turn out for you. Out of 100 ways things might turn out of you. There's a few of these really nasty ones, but most of them are pretty good. So just because something nasty might happen doesn't mean it's 50-50. So all the time we're trying to communicate the fact that there are both a number of possibilities, some good, some bad, but they're not all equally likely. And
I guess my point was, do you think the media do that properly?
Oh, the media are terrible, yeah. No, absolutely dreadful, because they want a story. So the whole point is that they will promote minority views. So the whole point is to try to counter that.
Well, now I'd like to thank David very much for his contribution. David has kindly agreed to stay around, I think, for about half an hour. So if people wanted to catch up a bit later on before he heads south.
And just one final point. Oh, I've gone back. Anyway. I did have a final slide to point out that that is me. So I've got two roles here. I'm a statistician and a customer. So thank you very much indeed.
Thank you. That's wonderful.